All right, so I'll go ahead and introduce Jeff again. For anybody who wasn't here in our last lecture, this is the second lecture of what will hopefully be a many to come series with Jeff Young, who is going to talk to us tonight more about merging exercise science and sports medicine. So really trying to highlight for us aspiring physiatrists how to incorporate physical therapists and exercise rehab specialists and personal trainers and nutritionists and all of the kind of additional support staff that are really involved in um, getting a patient truly back to 100%. Jeff has tons of experience in the field with this, and he has a lot of experience working with physiatrists specifically. And so he's a great person to kind of help us bridge that gap in between. And for anybody not registered for the mid-year meeting, an early plug, Jeff will also be speaking at the mid-year meeting. So if you like what you hear tonight, make sure you sign up for that, whether in person or virtual. But with that said, I will stop sharing my screen and turn it over to Jeff so that he can do what he does best and drop some knowledge on us.
All right. Thanks so much. I really appreciate it. And thanks for everybody who is attending. And like Andrew said, this is the second in a series before we start getting into the case studies. And so my mind frame with part one, and now this is part two, was I just know from experience that to give this kind of like 30,000 foot bird's eye view to start will make once we get into the actual case studies on joint conditions and exercises related to it, it's just going to make a lot more sense because I'm going to be referring back to these concepts on a pretty regular basis. So that's the whole purpose of it. And so what I want to do in this one is just quickly review some of the main things I talked about in the first one. And then I'm going to once I'm finished that, I'm going to talk about a concept which is ridiculously important to understand that few people have heard of, called Henneman size principle, and then something that I call the RPE method. And then I'll quickly just go over some joint friendly exercises, aerobic and flexibility program design concepts. And then just depending on the time, I'll also kind of go over a quick lifestyle medicine case study, a success story. And not sure if for some reason we run out of time and I can't go over that, then we can just save that for another time. But before I get started, let me also just say that please understand that I'm just kind of giving this bird's eye view. So I'm not specifically going to be going over this stuff in a lot of detail. And part of it is because of the fact that once we start doing the case studies session after session, you're going to be hearing these concepts over and over again, and they'll get ingrained in your head. And another reason is because with some of the stuff, it's like, for instance, aerobic and flexibility program design. I just kind of wanted to throw that in there because it's just good information for you to know. But we absolutely can break up the case studies every once in a while and just have a session on some exercise science and maybe get in a little bit more into, for example, high intensity interval training and sprint interval training and how to design those types of programs and how do they apply to special populations and things like that. So please just understand that I'm going to be flying through a lot of this stuff, and the purpose is not to go over in like a ton of comprehensive detail. So with that said, quick overview. The first several slides are just a review of the last time, where I kind of started off by talking about the medical rehab and fitness continuum, and more specifically as it relates to the attendees here, the physiatrist. And I put physical therapists, I know can also apply to chiropractors. Basically, it's just the rehab domain. So it could also be chiropractor or an athletic trainer, for example, but more commonly it tends to be the physical therapist. And then the fitness domain and the fitness professional. And basically what I talked about was that, when the physiatrist deems it necessary to refer the patient off for rehabilitation, commonly it's a physical therapist. But the problem that is too often a problem, it's not an absolute, but it's too often a problem, is that this is where it ends. And that's a problem because the physical therapy should really just be a short stay. It should be, and from a physiatrist standpoint, from the physician standpoint, you're the quarterback and you can quarterback this whole continuum. And you can help ensure that the rehabilitation doesn't end with home exercise programs, which it tends to for the general population, like 90+% of the time. And you can help ensure that the patient moves on from physical therapy into the fitness domain, which is really where they need to be. So one of the things I forgot to say last time, and after I finished, I just couldn't believe that I forgot this because it's really important. There are going to be times when you can and actually should bypass rehabilitation and refer directly to a fitness professional. And for those of you who aren't aware, for 15 years, I worked directly alongside Dr. Rob Gotlin. And for 16 years now, I've worked directly alongside Dr. Lisa Bartoli. And I also have several other physiatrists in my network. And there have been countless times over the last 16 years of my career where they have referred patients where it was a situation where they bypassed rehabilitation and they felt that it would be better for the patient to be placed on a total body strength and conditioning program that included therapeutic exercise, because of the person being weak and deconditioned. And maybe it was a situation like non-specific low back pain or patellofemoral syndrome, as opposed to something a little bit more severe, for the lack of a better term. But please just understand that because of that, and this is I'm just giving you my opinion, and you can do whatever you want with this information. But based on my experience and my biased opinion, if I was a physician, if I was a physiatrist, I would make sure that the physical therapists or chiropractors, whatever the case may be, has fitness professionals within their network. And I would only refer to PTs, or maybe not only, but I'd really highly recommend that they get fitness professionals within their network. And I would basically tell them, I'm getting ready to send Jeff Young to you for such and such condition. And I don't want his rehab to end with a home exercise program. I want to make sure that he is then passed on to a qualified exercise specialist. And this really should be happening regularly. And I'm going to be going in Knoxville in a couple of weeks. I'm going to be saying a lot of the same stuff, but I'm actually going to be giving even a larger bird's eye view of something that's going on at a government level right now that most people aren't aware of. Where there's actually changes that are going on in the background with the system as a whole, where this stuff really needs to start happening. And we don't need to wait several years for this to happen. You guys can, why I'm trying to plant the seed now, because as soon as you start practicing, you can make this stuff happen. So in any case, therefore, since you can bypass rehab, you should also have fitness professionals in your network. And with that said, I'm begging you to please take my information down, like my cell number, if you want, my email address, because I can really help you with this. Doesn't matter where you are in the country, I can help you connect with qualified exercise specialists. I actually just found out today that most likely tomorrow, the board of directors for the National Strength and Conditioning Association is going to approve a special population, special interest group that I'm going to be chairing. And I just learned today that I'm probably going to find out for sure tomorrow, but they basically said it's going to happen. And so as the chair of this group, I'm going to have access to thousands of qualified exercise specialists throughout the country. And I'm also just really involved with the ACSM, American Council on Exercise, and the National Academy of Sports Medicine. So I really can be a resource for you to help with this process and the vetting process as well. So please keep that in mind. And then what I did last time was I went over the stages of rehab into just a real quick review. And this is also just generally speaking, there's obviously going to be a little bit more to it, but generally speaking, stage one is where the physical therapist is concerned about reducing or negating pain or inflammation, restoring joint range of motion. And stage three is where they're going to restore or improve motor control, eccentric control, and balance strength around the affected joint or joints. And so, in long-term rehab, like if it's ACL injury, then obviously it's going to go past this and into stage four, which I'll talk about in a second in more detail. But part of the problem with insurance dictating, just these short 8, 10, 12 visits to physical therapy in so many situations for the general public, this is typically all the time they have to work with, and they never really get to stage four, or if they do, it's just like the very beginning, and it's a major problem because these stages aren't really doing an adequate job of strengthening tissue, which is ultimately what needs to happen in order to reduce the risk of injury or reduce pain. And so it ends up, creating this negative cycle that really exists, where the patient ends up being in what a lot of people call physical therapy purgatory, where they just keep cycling through. They feel good for a while, and then all the PT really did was get them back to how they were prior to going to PT, which in so many cases was weak and deconditioned. And they just get them feeling better. And then because they didn't get that much stronger or not significant, next thing you know, they're being recycled through this whole spectrum. So it's just another reason why, from your standpoint as an attending physician, as a physiatrist, you really have to ensure that you're quarterbacking this continuum from your patient standpoint, and just make sure that whenever possible, it doesn't stop at stage 3. And where stage 4 is where it includes more of the kinetic chain. Perfect world situation is heavier loads, multiple planes of motion. You're starting to get into force absorption, more variety, a wider spectrum of repetition ranges. And ultimately, you want it to be total body and not just the joint or joints that were affected being worked on in PT. And then what I did last time was I just focused a little bit more on stage 4 and just talked about how, athletes move from rehab to strength and conditioning. It's just, because they're athletes, what they do. It's what they need to do, but so should everybody else. It shouldn't just be something for athletes. And that, once again, too often the general population is discharged with low volume, low intensity, low variety home exercise programs for only the part of the body that was injured or in pain. Underdosing and underloading are huge problems in physical therapy. They come in either sick, or maybe by sick, I'm talking about, having the diseases that go along with so much of our population, whether it's diabetes, metabolic syndrome, fibromyalgia, MS, lupus, on and on. And those things aren't being addressed as well. Some of it is not the physical therapist's fault. Some of it is just because they're only there for 8, 10, 12 sessions. So I'm not, pointing fingers negatively at PT. So much of it just has to do with our medical system. But it's a problem. And it's just a reason why fitness professionals, qualified, need to be part of this continuum, a much greater part. And ultimately, their overall health needs to be addressed along with their musculoskeletal conditions. And I said this last time, I think, but I also just want to let you all know that another thing that's going on with me right now is I'm actually working with the American Physical Therapy Association on this stuff. So I've been brought on as like they haven't really titled me yet. This has all happened within the last 3 or 4 weeks, but it's basically a medical fitness bridge the gap consultant for them. And I've teamed up with another physical therapist in Seattle, and we're actually going to be doing a regular podcast and creating a ton of educational content. And it's all related to this stuff. And basically, as a PT, he's a huge believer that the PT field needs to change and use their expertise in addressing health conditions along with musculoskeletal conditions. And the part of the physical therapy that I'm working with is called the Health Promotion, Prevention, and Wellness Council, which is kind of like a lifestyle medicine council. And fortunately for me, they're all believers in this stuff too. So I just want to make you aware, in case you aren't, that the APTA actually has, factions within it that are believers in this stuff. It's just unfortunate that as a field, it just hasn't really infiltrated enough into the field. So in that case, it begs the question, who do you refer to, and how do you know when to refer to a physical therapist versus an exercise specialist? Once again, this is a review from last week, so I'm just going to fly over this. If the patient needs the following modalities, or if the pain the patient has experienced is sudden or rapid, occurs in the beginning or middle of range of motion, includes swelling and inflammation, sharp stabbing, burning, numbness, tingling, and or significantly affects their activities of daily living, then absolutely you want to refer to a physical therapist. Otherwise, it can be an either or situation, because it's not like physical therapists can't do the following. But the point I'm trying to make is that a qualified exercise specialist can. And it's another reason why you want to keep them in mind. So while people like myself don't diagnose or treat injuries, we can work around the injury when necessary, avoid it completely, adjust foot and hand position, joint or joint angle, whereby doing so alleviates pain, reduce the range of motion or load, whereby doing so alleviates pain, and revolve exercises for the injury area around joint friendly exercises, which I'm going to be getting a little bit more into later in this presentation. I didn't have time to do it last time. And then include therapeutic exercise along with the total body program. So basically what it comes down to is that when pain and swelling are minimal or no longer exist, which going back to that chart that I had in the previous slide, that's basically phase 1 and phase 2. So phase 1 is reducing pain and swelling, and phase 2 is restoring range of motion to at or near normal. Once those two things happen, then what's left over is therapeutic exercise, whether it's strengthening, balance, what they call motor control exercises, which for whatever it's worth, I'm a believer that, either most or all exercises are motor control exercises, but that's for another time. But in any case, once the swelling no longer exists or is significantly reduced and range of motion is back, the individual is going to benefit from a focused, guided, individualized, progressive, total body strength and conditioning program, which once again includes therapeutic exercises as needed. So, another thing I think I mentioned last time, which I'll briefly say again, is that when I first started working with doctors Gotlin and Bartoli in a Mount Sinai Beth Israel system here in New York City back in 2006, called the Center for Health and Healing, I didn't know any of this stuff. And so basically the physical therapist took me under their wing, which I'm eternally grateful for. But what it did was, for about the first 7 years, I was already 10 years in my career when I started this facility, and I was a strength and conditioning coach. And what it did was it kind of flip-flopped me into being what I now call a pseudo physical therapist. I was just being way too conservative. At the time, I didn't realize it, but I turned into just being way too conservative with my intensity, with my exercise selection, with my progression. And a physiatrist, his name is Dr. Dave Perna, and he works at Mount Sinai Spine Institute here in New York City. And he was a D1 honorable mention All-America athlete, competed nationally in Olympic lifting, etc. And so he really got it from the physiatrist standpoint, in other words, the physician standpoint, from an athlete standpoint, getting injured and having to go through the whole continuum and be rehabbed back to an elite level. So he really saw the whole continuum. And he's actually the one who influenced me into, you need this stuff. You need to be conservative for a while and therapeutic exercise, etc. But ultimately, you got to get people strong. And so he kind of flopped me back into being a strength and conditioning coach who uses ACSM and NSCA guidelines as my overall framework, and I insert therapeutic exercise as needed for the joints. So this is the kind of stuff I'm going to be going over in a lot of detail when we get into the case studies, starting in the next presentation, hopefully in June. So in any case, then I quickly went over sports medicine concepts, which I'm not going to go over in a lot of detail here. It would just take too much time. But the gist of it is that there are 6 primary components to a healthy musculoskeletal system. There's neuromuscular control, which basically just means that in any movement or resistance of movement, like a plank, the right muscles are producing the right force at the right time, and it is synonymous with proper form. So neuromuscular or motor control just means proper form. And strength is a major component of motor control. And then strength is a component of a healthy musculoskeletal system. Obviously, if you're weak, then you're going to be at greater risk for injury or joint pain. Strength endurance, which is also known as local muscle endurance, is a component of a healthy musculoskeletal system. That's kind of where the conditioning part of strengthening comes in. Joint stability, which you can improve joint stability without strengthening, but you pretty much are going to need to strengthen to really optimize joint stability. So, and then posture and alignment. But my main point was, when I went over this in much more detail last week, is that of the 6 components of a healthy musculoskeletal system, the first 5, strength, or more specifically, balance strength, plays a major role. And what you have left over is mobility, which you also want to balance. Oops, sorry about that. You also want to balance around each joint. And so that gets into this mantra, which I'm going to get to in about 3 slides, but it gets into a mantra that I kind of just learned over the course of time through discussions with physiatrists and physical therapists, our journal clubs, but also just my own knowledge of exercise science and just experience training clients. And it kind of put it all together, or it took several years for me to really, the light bulbs to go off in my head. But I started realizing that there is literally a mantra that applies to pretty much every condition, and no matter where it is and no matter what it is. So I'm going to get to that in a second. But another thing I went over was just some general exercise science concepts from an application standpoint. The ACSM, American College of Sports Medicine, has their own mantra where they say start low and progress slow, or start low, go slow. The start low part, and there's a zillion ways you can go about this, so I'm not acting like it's my way or the highway. This is how I go about it. I just think it's the most logical and the easiest way, and it also really corresponds with what they're doing in physical therapy. If you really look at this closely, from a repetition standpoint, I'll start most of my clients off at 10 repetitions per set, which is generally what they're doing in physical therapy. And the purpose of the phase is to determine their available pain-free range of motion, just like physical therapy. I'm also determining exercise selection at that point, safe exercise selection. I'm teaching them names of exercise, proper form, flow of a session. I'm using rate of perceived effort scales to determine their initial loads, which I'm going to go over here in a minute in more detail. And I'm slightly increasing the intensity during the course of the phase and using cueing, such as verbal, visual, and tactile cues, to help establish mind-muscle connections, much of which they're doing in those first 3 phases in physical therapy. So I'm really mimicking what's going on here. And what determines the end of the stage is that the client is showing proficiency in their movement. It's starting to become natural for them with their squats, hip hinge, lunge, push, press, etc. And I'm also starting to increase their effort from going from like a warm-up type of effort and being really conservative with my loads to true working sets. And once they got to that point, it is time to progress. And there's a zillion ways to progress, but the most common sense way, at least to start with, in my opinion, is something called linear periodization, where generally speaking, you would move them from that 10 repetitions per set up to 12 to 15. You stay there for a 3 to 4 week phase. You increase strength within that phase so that in every exercise, they're a little stronger in week 3 or 4 than they were in week 1. And that prepares their mind and their body for when you dropped 2 reps. You stay there into the 10 to 12 rep range. You stay there for 3 to 4 weeks. You also increase strength. And there's other things you can do also by adjusting rest periods between sets, etc. But just generally speaking, you do this in a linear, systematic fashion. It's systematic variety. And it's just a way to start them with light loads and move them through moderate loads. And then if they're capable, into the heavy load range. You're also starting to, this is that stage 4 stuff. This is now where you're starting to increase their effort or proximity to muscle failure. You're starting to vary session intensity so that some are light to moderate and some are hard, because you don't want to always go hard, 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 but you also don't want to always go light, light, light. You start increasing variety, set volume, et cetera, et cetera. And now this leads to my mantra, which you want to balance flexibility or mobility around every major joint in a perfect world situation. And you're going to do that by putting them on a proper flexibility program. So where they're tight, get them mobile, because that's how you balance flexibility and mobility around every major joint. Where they're weak or hypermobile, get them strong. And that really should just be a function of an ACSM, NSCA, once again, the 2 governing bodies in exercise science. If you're following their guidelines, then just by default, you're going to be balancing strength around each joint. You want to get them out of a beginner range of strength, which by default, you will do that if you go through that linear periodization model that I described in the previous slide. And you want to ensure proper form, which is going to be improving their motor control. And if you do those things, this is the corrective in either a injury prevention or post-rehab atmosphere. These are the correctives for nearly every condition, no matter what it is or no matter where it is. And once again, this is why I wanted to kind of go through these concepts, because as I go through my case studies, you're going to start seeing this theme over and over again. So that is the review of what I did, of what I went over the last time. Now we're getting into these like four or five concepts for today's presentation. First is called Henneman size principle. I'm going to give you a quick background on this. Graduated from Penn State in '96. My academic advisor, Dr. Bill Kramer, who built the National Strength and Conditioning Association and is widely considered the premier strength and conditioning researcher in the world. And I was smart enough to maintain a mentor-mentee relationship with him for the first 11 years of my career. Wish I could tell you how much I learned from this guy. But in any case, in 2006, I think, maybe 2007, he had now gone to University of Connecticut. I was in his office when we were just talking about things. I was picking his brain, and he asked me if I was familiar with the size principle. And I told him that I've heard of the size principle, but I'm not familiar with it. And he scolded me. And he said, strength training as a system revolves around the size principle. You need to know it. And he then got on his chalkboard in his office and he explained it to me the way I'm getting ready to explain it to you. And it really is a ridiculously important concept to understand, even from the physician standpoint. So it basically states that motor units are recruited in order of size, which is why it's called the size principle, from type 1 or endurance fibers to type 2 strength fibers. So this is just a little stupid graph that I created that just shows that under a microscope, this is like a pretend looking under a microscope, your type 1 fibers are going to be the red small ones, and your type 2, which come in two basic categories. There's a whole bunch of subcategories, but basically it's type 2A, which is your mid-size, and type 2X's, which are your large. But the point is you have two types of motor units, strength and endurance, and based on the task or load at hand and the proximity to muscle failure, that is what determines the number of motor units recruited. So the point is that the easier the task, such as standing up from sitting to stand, walking, brushing your teeth, or lifting a 3-pound weight to put it on a counter or something like that, the body's only going to recruit the amount of muscle fibers needed to perform the work and not one more. And so, like, for instance, if I were to flex my bicep, or for instance, if I were to curl a 10-pound dumbbell, to your naked eye, it might look like my whole bicep is contracting. But under a microscope, only the motor units and corresponding muscle fibers that need to do the work are actually producing force, and the rest are relaxing and they're just going along for the ride. And that gets to the third little box here. Only activated or recruited motor units are trained. So if you aren't activating and recruiting them, then they can't possibly be trained. And to be trained, there's more to it than this. Training effect needs to also be optimal frequency, optimal volume. So there's a little bit more to this, but one of the most important things is the fatigue needs to occur. So you can have all the frequency you want and all the volume you want, but if you're never in a fatigue state, you aren't training anything. So it's an extremely important concept to understand. And I just threw this chart up because if you look at the title, you can look this up yourself. I would actually recommend that you do. It's a study or review called Muscle Activity and Inactivity Periods During Normal Daily Life. And if we had the time to focus in on this, the gist of this chart is showing that in most of our activities of daily living, such as sitting, walking, climbing stairs, things like that, only 4 to about 10 or 15% of muscle tissue is being activated. And even with climbing stairs, it only gets up to like 20 or 25%. So the point that Dr. Kramer was trying to make to me, that I'm going to be making to you over this slide and then the next two slides, is that most of the population isn't strength training, right? Only about 10%, which means 90% are never really trained. They might be activating in a moment in time strength fibers, but they're not training their strength fibers. It is a major problem. And even I'm going to get a little bit more detail on another slide, but the point is that this is why frailty syndrome and people just continuing to get weaker and weaker over the course of their lifetime, because they're not activating and training muscle fibers because they're never strength training. And we really need to get them into that domain. And you guys as physiatrists can ensure this through the physiatry, rehab, fitness continuum, so that you're making sure your patients are being guided through this entire continuum, so it doesn't just stop with home exercise programs. So I just want to put this chart up real quick, basically just to show that when it comes to strength training in different rep ranges, the rep range you work out in determines how your body's going to respond and adapt. So in the 1 to 4 rep range, assuming you're loading up so that you're lifting, to at or near muscle failure with the heaviest weights you can lift. This is known as very heavy weight. 4 to 8 is heavyweight, 8 to 12 is moderate, 12 to 15 is light, and 15 to 20 is very light. So from a Henneman size principle standpoint, 20 and above, you aren't activating strength fibers. If you can perform any task, whether it's in the gym or if you can walk for more than 20 steps, which nearly everyone on this earth can, you are not activating strength fibers. The load has to be such that for most people, it's in approximately the 12 to 15 rep range to even begin activating strength fibers. And optimally, it's going to be in the 1 to 12 repetition range where strength fibers are activated, and then on a proper program where they are trained. So the point of all this is that with activities of daily living that most people are doing, whether it's yard work or vacuuming their carpet in the house or carrying groceries or bags or walking or climbing a set of stairs, this is very low muscle activation. And once you get into the jogging domain, it still is only like maybe 25 to 40% of your tissue. And strength fibers aren't activated until until the load is such that at least 60% of your tissue needs to be activated. Then your body will start activating strength fibers. So that's part of the reason anyways, why jogging or running is an endurance activity. It is not strengthening you. It is not activating and training strength fibers. So you really need to strength train. And yes, sprinting, there's going to be some outlier situations, sprinting or people who habitually like high intensity interval training, or if they're running stairs all the time, there's going to be outlier situations, but generally speaking and optimally speaking, you need to strength train. So if you have any questions on that, please write them down or whatever. And hopefully we'll have time at the end of this that I can answer questions, or we can just do it in a future session. So now another extremely important concept, possibly right up there with Henneman size principle, one of the most important concepts in resistance training that exists, and that is subjective intensity. So unless you're a strength athlete, like a power lifter or strongman or Olympic lifter, most people, when they go to the gym, are not taking sets to true muscle failure. Therefore, and really, even if you are a strength athlete, you still shouldn't do that all the time, because it's just too, stressful on joints and central nervous system. So the point is that most sets are subjective intensity. They're subjective in nature. They are not being taken to muscle failure. And therefore, we need to be able to differentiate as to whether a load is a warm-up or a true working set. And there's something called the RPE, rate of perceived exertion, rate of perceived effort. And I personally like to say RPF, which is rate of perceived fatigue, but they all mean the same thing, which is the merging of 4 concepts. And I'm going to fly through this. We're going to be talking about it more later on, but if you have any questions about it, please let me know. Basically, RPE scales, like on a scale of 1 to 10, with 1 is, you're putting almost no effort into the set at all, and 10 is muscle failure. These scales are meaningless unless you have other variables that you can use to try to create more objectivity with these scales. And that's where repetitions in reserve, that's what RIR stands for. Repetitions in reserve, something called face of strain, or the look of strain on your face, and the velocity of movement. That's where these 3 come into play. So RIR just means how many repetitions were truly left in reserve when you terminated a set shy of muscle failure. And the way you can kind of objectively determine that is the look of strain on your face. But the most important of these 4 variables by far and away, and I hope you got to remember this, because this is my main point, is the velocity of movement. So flying through this chart really quickly, And I could really either start at the 1 to 2 end or the 10 end to explain. Doesn't really matter. I guess I'll start at 10. So if 10 is a muscle failure, it means that from a velocity of movement standpoint, the velocity came to a stop. So I hope you all have some experience resistance training. And I know you can't really see me, but if I was to do like a seated row, and so I'm rowing and maybe I'm doing 10 repetitions. So the first X amount of repetitions, maybe it's like the first 6, we'll say. If you look at the speed of the movement, it's all going to look the same. But at some point, and in my little hypothetical situation here, we'll say it's at rep 7, you're going to start to notice that that despite the intent of pulling with the same velocity, there's going to start being a look of strain on my face. And you're going to start noticing that I'm starting to, the velocity movement is starting to slow a little bit more. Once it has slowed, neuromuscular fatigue has truly set in. So once it has slowed where the intent of velocity still exists, neuromuscular fatigue has truly set in, and it is guaranteed that if you decide to do another rep, so now I'm on my 8th rep of a 10 rep set where I'm taking myself to muscle failure, the 8th rep is going to be a little bit slower than the 7th because fatigue has now truly kicked in. So the point is that on this continuum, on this scale or spectrum, and let's actually look down at 1 instead of 10. So at 1, it's very little effort. There's no fatigue. You aren't experiencing any fatigue at all. There's no look of strain on your face unless you're faking it. And the velocity of movement, is not slowing at all. Once you get, and also even 3 or 4, it's really hard to distinguish this because from a 1 or a 2, because it's still significantly far from muscle failure. There's still very little fatigue. The look of strain on your face is still probably not going to be any unless you're faking it. And the velocity movement is still not slow. But once you get into 5 or 6, now you're starting to get in closer proximity to muscle failure. It's still a warm up, but you're getting closer. And so maybe you'll start to see a little bit of look of strain on the face. And the velocity movement will not have begun to slow, but for an experienced person, whether they're the lifter themselves or a coach like myself, you can start to tell, you know what? I can tell that person's getting close. I can tell that probably on the next rep or maybe 2 reps from now, I'm going to start to see some slowing of the velocity of movement. But the point is that once that velocity of movement truly slows, now you're at a 7. Now this is a true working set. And you actually could stop at a 7 or an 8 and get the benefits of strength training. You don't have to take yourself to a 10, nor should you, but you have to take yourself to the point where velocity of movement at least begins to slow for it to be a true working set. So this is a ridiculously important concept because so many people are going to the gym and they're just, they think they're loading up enough to get the adaptations and results from resistance training. But the truth is they're not loading up enough for the velocity of movement to slow. And also it's important because in that early stage, the initial training where you want to start low before you start progressing, you actually don't want your client or your patient to be training at a 7 or an 8. That's too high of an intensity. You want to start them at like a 4, 5, or 6 and make sure that before we take them out of their comfort zone, we make sure that their body, because they're having joint pain, that it's responding well. And you do that for X amount of weeks, and then you start to progress into true working sets. But this is a problem, man. Not in physical therapy and in fitness training. I'm not just pointing fingers at rehab. There's just too much underloading going on, and there's just not enough understanding of these concepts. So the better you guys understand these concepts, the more you can vet your physical therapist and vet your trainers that you're referring to and start, whether it's quizzing them on this stuff. How do you go about determining your loads for the patients I'm sending you, and quiz them on this stuff. I guarantee you, if I was in your position, I'm a physiatrist, I guarantee you I'd be doing this because I don't want any underloading going on with my patients. So in any case, now we're going to get into joint friendly exercises. I'm going to fly through this as well. Because once again, I know I'm repeating myself probably too many times, but we're going to be hitting this ad nauseum in the case studies going on. So you'll really know this once we get into the case studies. But basically from a shoulder, there's something known as a safe zone if you aren't familiar with it. And the gist of it, and this is just it's a concept, so it's not written in stone, but generally speaking, in shoulder flexion from 0 to 90 degrees is going to be safe, even with most shoulder conditions, unless it's an outlier situation. Once you start getting above 90 degrees, especially under loads, especially under moderate to heavy loads, if the person has a condition like impingement syndrome or something like that, then it doesn't mean it's completely unsafe. It means that on a continuum, you're starting to get outside of the safe zone. And just to be aware of that. From an abduction standpoint, at 0 to 60 degrees is typically safe. The impingement risk is somewhere around 60 to 120 degrees. And then once you start getting up in here, 120 to like 170, usually there's more subacromial space, not as much impingement going on. But once you get up in here into 180, then the risk starts to increase again from the abduction standpoint. And then the high five position, which basically just means that you don't want that once you get your humerus above 90 and then externally rotated so that your hands a little behind your head, then that's when you're really putting your rotator cuff, your capsule on a lot of stress. So especially when you're under moderate to heavy loads, under conditions of fatigue, this is when you're unsafe. So that's what the safe zone means. And I just created a little like 90-second video just to give you insight as to what this might mean practically. So this is a face pull, which is a very safe exercise and shoulder exercise in most situations from a post-rehab standpoint. Here's all reverse flies. Here's from high to low. Here is from low to high. You want to vary your angle so you get different muscle tissue involved. Here's from straight across. The next one is a dumbbell. But these are all shoulder-friendly exercise, strengthening the muscle, upper back, musculature, safe on the shoulder. This is I'm just going to stop this for a second. Cable lateral raise. Let me just reverse it just a little for a second. This is a cable lateral raise, but if you look at it, it includes a little bit of external rotation. So you're hitting the deltoid and a little bit of your rotator cuff musculature. So this is safe. Or if you want to really isolate the rotator cuff, here's an example, 90-90 exercise. Then you got your well-known scaptions in most situations in a post-rehab atmosphere, or dumbbell lateral raise are in your safe zone. And then you can start progressing to things like landmine press. Here's with a cable or with barbell, where you're not completely pressing overhead, but you're starting to head in that direction. And then I'm going to stop this for a second. So you're going to see at the end of my presentation today that the first case study we're going to do in the next time is actually going to be me, because I am currently rehabbing from a ruptured bicep, large tear in my supraspinatus, and partial labral tear. And so from a pressing standpoint, yes, I could keep my humerus, my upper arm, tucked against my torso if I wanted to keep it really safe. But you don't really, basically the safe zone from a pressing standpoint is abduction around 45 to 70 degrees. So once you get beyond 70 and you're abducting like 75, 80, 85, 90, now you're really starting to put too much stretch and too much stress on the capsule and the rotator cuff. But in the 45 to approximately 70-degree range of abduction, it's safe. And my injury just happened 7 weeks ago, so it's still a fresh injury. And here I am, look, it's still baby weight, 40 pounds, but I feel no pain whatsoever in the, you can see I'm at about 45 degrees. So that's just to give you an idea of what I mean by safe zone from a shoulder standpoint. Let's go to the next one. Spine. The gist of this is you have 4 things that the spine can do. It can rotate, laterally bend, flex, and extend. And you want to train that from an anti standpoint and from a moving standpoint. So you have anti-rotation, anti-lateral bending, anti-flexion, and anti-extension, and then you have moving in those directions. And you don't have to separate this completely where you only work stabilizers for a while before you do movers. You can do this concurrently. But generally speaking, and from a safe standpoint, it's obviously going to be a lot safer if you just work your stabilizers first. And in other words, you take movement out of the equation. So that's typically what I'll do. You refer someone to me who's got low back pain for whatever reason, the first thing I'm going to do is, I'm in their program design, is I'm going to, from a core strengthening standpoint, is I'm going to take movers out of the equation. And we're just going to do, I have another short video to give you an example of what I do in that situation. But then what you do is, once you've established either some baseline strength from a stabilizing standpoint, isometric standpoint, and or once you've come to realize in your first few sessions that they do already have a half decent baseline of core strength, then you can start inserting movers into the program. And once you do that, I typically just do it in like 2 to 3 week blocks. So for instance, I'll start having them flex their spine in the form of a crunch, but I'll just have them do it in a really short range. Or I'll have them do a cable rotation, for example, but instead of going from side to side, it might just be like a pulse from 11 o'clock to 1 o'clock. So the point is, once it's time to insert movers in the equation, you just do it in small, tolerable increments. You do it in 2 to 3 week blocks. You make sure their body's responding appropriately. And if it is, then you make the executive decision as to how much you want to increase them. So real quick video. This can mean things like a modified plank from a stabilizer standpoint, or a regular plank, a modified side plank like this, or a regular side plank working your obliques from an anti-lateral bending standpoint. Here's an example of Pilates hundreds, where your torso obviously is not moving. Here's bird dog, I'm sorry, dying bug, where the spine is not moving. Here's what I call a prone bird dog rather than quadruped. Works the multifidi a little bit better than a quadruped bird dog. As an example, here's just a low back extension hold. But these are all examples of isometric contractions that are safe. And then once you insert movers into the equation, here's an example of a very safe way to do it. You have them pull their hips to 90 degrees. This is going to take their lumbar spine out of the equation, so that all the movement is really just coming from their thoracic spine. And you just turn this into a nice, safe mover exercise. And then over the course of time, you can have them do a regular crunch or something like that. And then, like I said, in this particular video, she's going more than what my example really should be, which is just a pulse from like 11 o'clock to 1 o'clock. But you can start with that pulse and then eventually progress to something like what you see in that picture. And then here, I'm sorry, in that video. And then here, I'm just giving examples of strengthening, because you obviously got to strengthen the glutes too. Here it's glute med strengthening exercises. And then the truth is, there's crossover between spine and knee friendly exercises, because deadlifts are spine friendly, squats are spine friendly, lunges are spine friendly, as long as they're done with appropriate loads, proper form, and appropriate progression. They are all spine friendly as well. And then getting to the knee, there are knee dominant exercise. I'm sorry, there are hip dominant exercises and there are knee dominant exercises. And you can do this concurrently. It doesn't have to be start with one only and then move to the next, but you might want to emphasize hip dominant first, because it's kind of taking knees either completely out of the equation or mostly out of the equation. And then you can progress to knee dominant exercises down the road, or once again, do it concurrently. But examples of hip dominant would be hip bridges, hip thrusts, deadlift variations, and knee dominant would be squat, multi-directional lunges, and step ups. And I'm not really going to, because we're kind of running out of time here, I'm not going to go through this whole video, but the gist of it is, I'm going to fast forward here. Deadlifts are safe on the spine when performed properly. And squats can also be, I'm sorry, on the knee. And squats are, a lot of people think that squats are bad for your knee if you have a knee condition, but the truth is, it just depends on what the condition is. And you can always vary your type of squat. So it could be a barbell, but it could also be, a goblet squat with a kettlebell or a dumbbell, or a cable version of a goblet squat. So you can adjust range of motion and the type of squat to make it a knee-friendly exercise. Okay, so now these are my last several slides, last 2 or 3 slides. Aerobic training program design. For those of you who aren't aware, to design aerobic and flexibility training programs, just follow an easy acronym called the FIT principle, F-I-T-T. Actually, it's the FIT P principle, for P for progression. So F stands for frequency, I for intensity, T for time or duration, the other T for type, and P for progression. So I'm flying through this really fast, but basically from an aerobic program design standpoint, and you guys can do this um, in your clinic with your patients if you want, because you literally can set someone up on an aerobic program from a general fitness standpoint in 5 or 10 minutes if you want to, once you know how to go through these principles. So basically, frequency can range from 1 to 7 days per week. Time and desire are common factors which determine the frequency, and also whatever your goals are. So for instance, if it's weight loss, you want the frequency to be higher. If it's just general fitness, it doesn't necessarily have to be higher. More on that later. There's two types of intensity, objective and subjective. Objective is going to be measuring your heart rate through like a heart rate monitor, obviously. And then subjective intensity is using your RPE scales, which I'll get into in some other presentation, using similar RPE scale as what I showed with the strength, except that you're using a talk test and how winded you are versus the velocity of movement. Duration can vary a ton depending on the type. It could be as little as 5 minutes because they're deconditioned, or maybe 10 or 15 minutes because they're doing higher intensity interval training, or it could be 30, 45, and 60 minutes because they're doing long, slow duration training. And then progression, you can progress all of those, all of the above as a way to progress. So you can progress frequency, you can increase the intensity, you can increase the duration, or you can make the type something a little bit more challenging, like going from a stationary bike to starting to do like a walk jog type program or something like that. And then from a flexibility program design, it follows the same principle. Frequency is also going to range from 2 to, it could be up to 7 days per week. The tighter you are, areas that are tighter are going to need higher frequency. And so it kind of depends on what the goal is for the particular area. An area that is hypermobile, you really need no frequency at all. If it already is normal range of motion, then the frequency can just be 2 or 3 days a week to maintain it. But if it's tight, you probably need higher frequency. Intensity just means, how hard you're going to go into the stretch, which should basically be mild to moderate discomfort. I'm going to get into the time in a second of what that means. Type just means the different types of stretching, such as passive, active, proprioceptive, neuromuscular facilitation, etc. And I'm going to talk about progression here in a second with this video right here, which is only about a 30-second video. So there are two ridiculously important concepts. They're kindergarten concepts with flexibility training that are, in my biased and frustrated opinion, are not getting out there to the general public via sports medicine and exercise science. So I'm putting the blame on everybody. And that is, if the goal is to improve range of motion, yes, you need your frequency. If it's only once a month, you aren't going to improve your range of motion. Yes, you need your duration. But if you aren't finding a second end range of motion, you are never stimulating your body to improve range of motion. And this is not being, this information is not being transferred over to the general public. So what I mean by that is, and I'm using hamstrings as an example, but applies to everything, every muscle. She just found her first end range of motion. And so what you do is you find your first end range, and your body's obviously going to tell you when to stop. So you felt some mild or moderate discomfort. And there is a neural relaxation that naturally occurs at about the 15, 20, or 25-second mark into the stretch. And so if you are mentally relaxing into the stretch and you hold it for 15, 20, 25 seconds, there will be a natural relaxation that will occur, which will then allow you to creep in, muscle creep, which you're going to see here in a second, to creep into the stretch and find a new range. And then you also hold it for 15, 20, 25, 30 seconds, or a minute if you want, etc. But the point is that there are two components that need to be explained to the general public. And that is, there's a time component and a creep component. You have to stretch and hold that stretch for a approximately 20 seconds or so for that neural relaxation to occur. And then if your goal is to improve joint range of motion, you need to creep and find a second end range. If you don't, and you're always stretching to the same end range every single time, you are not providing a stimulus to your body to improve joint range of motion. So that's what I had to say on flexibility training. And then I wanted to get into a multiple sclerosis case study, which I will have to do another time. It's a lifestyle medicine case study. But one thing I will show you to maybe entice you is, oops, hold on, let me backtrack. Nope, you know what? I can't. So I'm going to end it with this. Next presentation topic is going to be me, because I just had this injury. I'm only 7 weeks into it. It's a fairly significant injury, and I am I spoke with 3 orthopedic surgeons, several physiatrists, like Dr. Gotlin, Dr. Mahajer, who's a member of the AOC PMR. You may know him, and a couple other physiatrists. And I spoke with about 4 physical therapists. I am bypassing surgery. I'm also going to bypass physical therapy. I'm going to rehab. I'm currently rehabbing myself back. So I think it's going to be a really interesting case study. Obviously, I'm biased towards it because it's myself, but we're going to start with this the next time. And with that said, it's 8:30. Unfortunately, I didn't have time to go through the multiple sclerosis case study, but please let me know if we have time for, 4 or 5 minutes of questions if you have any. And thanks so much for listening.
Thank you so much for that, Jeff. And I don't think there's any better case study than yourself. So it's always great to use yourself as the model. So one of the questions that we had, I'll start off the questions and then we'll open it up to anybody else. One of the questions that was submitted ahead of time, I just want to make sure I pull it up, is from your experience, how involved are physiatrists in the treatment or in the development of the treatment plan when it comes to exercise and functional therapy and balance coordination and all of that? Are we the ones that are specifically telling the PTs and OTs what exercises and movements we want to do? Or is that more of a delegation of a specific protocol, like lower extremity strengthening protocol or, balance protocol? And just kind of your experience with that.
Yeah, what an outstanding question. And this is why I don't want this to sound cliche. I am so happy to be doing this because the answer to the question is it needs to be way more involvement than it is. And the only way it's going to be is for you guys to be able to speak the language better. And, I don't want to make it sound like I'm pointing fingers in any direction because there's tons of problems with exercise science programs, and the fitness field is a borderline joke. So I could sit here for hours and rip on my own field. So I'm not pointing fingers. That we all need to fix things. And so the answer to your question is that it should occur a lot more. Now, so much of it is going to be logistics, like how much time do you have with your patient? How many conditions do they have that you're talking with them about? How many questions do they have? And so how much time in the time that you have with them can you even be talking about the prescription in detail? But generally speaking, there's not a whole lot going on. Basically, what's typically happening is you're listening to their complaints and reviewing their condition with them and the diagnosis and all that stuff. And then you're going to kind of give a starter prescription, which is then if you decide, obviously you might decide that they just need an injection, to reduce the pain or something like that. And that might be all that particular person needs. And you're not going to refer them to physical therapy. But for those who do get referred off to rehab or off to exercise specialists, you need to be able to speak this language because you probably aren't going to have the time you're only going to have the time to create a very basic prescription, maybe like 4 or 5 points on a little prescription note, card or something like that. And that gets passed on to the physical therapist. And then they expand on that. They then take your general, guidelines for the prescription, and they'll say, okay, so they want me to do make sure that I include in the rehab this, and this. So I'm going to take that and I'm going to expand on that treatment, based on their expertise. And so I hope that answers your question, but it needs to be way more than it is. And part of the problem is we just aren't speaking each other's language well enough.
I see Kevin has his hand raised. So Kevin, go ahead.
Thank you. Hi, Dr. Young.
First of
Yeah, I'm
all,
a
let me
third year
just say
medical.
I'm not a doctor, so you can
Oh,
actually just you can call me Jeff. I'm a
okay.
kinesiologist. Call me Jeff.
Jeff, so I'm a third year at KCU, and well, thanks for answering. I submitted that question, so
Oh, okay.
thanks for answering that. But my question is, you were saying how there's the exercise specialist, there's like a bridge that usually isn't gapped. The patient who's rehabbing ends up doing gets a regimen of home exercises to do, and it kind of just fizzles out like that. And like from my own experience, I've had like 2 knee and 2 ankle surgeries, and with that kind of is I really related that because that's kind of what happened after was just I had a few PT sessions, and then it kind of was just on my own after that. So I'm wondering, and you're saying how you're consulting and talking to a lot of people about this big issue. Is the issue the kind of lack of knowledge that maybe physiatrists or orthopedic surgeons that are involved in the rehab process, or is it kind of more like a health insurance financial issue that it's almost like that some people in the industry might think, oh, this would cost more, this is not exactly necessary, we just need to get them to this baseline, and technically that should be adequate and that should be appropriate from like a professional medical healthcare standpoint.
Yeah. And so it's really, it's all the above. Some of it is just the lack of knowledge and lack of that knowledge being transferred on to the patient, and realizing that, and this is something that went in Knoxville, I'm going to be hopefully hitting on in a little bit more detail, the fact that the behavior change starts with the physician. And then actually physical therapy is actually behavior change. PTs don't realize that. So they just kind of see it as I'm fixing this joint problem standpoint, but they're actually initiating behavior change. And so some of it has to do with just a knowledge and transferring that knowledge through the continuum and onto the patient. But absolutely, some of it has to do with insurance and what a joke insurance is and how limiting it is. And some of it has to do with perceived, and I really mean perceived with capital letters, underscores, and exclamation points, perceived barriers from the patient and actually from the physical therapist that, oh, we can't afford it. You charge too much. And from your guy's standpoint, the attending physician, you can play a role in changing this stuff and saying, no, this is actually, you don't have to do ongoing for the next 3, 6 months, a year of your life where it's this huge expense. It would benefit you to even just get 5 sessions so that you can be set on the right foot. I have some great exercise specialists in my network, and this is an investment, not an expense. And just change the wording and change the mind frame. And also there are ways to make it less expensive. There can be virtual. A lot of insurance companies reimburse, so it's not a copay thing, but it is they do reimburse. There can be partner training where 2 people share the cost. There are so many ways around this stuff that I can hold sessions on if you want me to, and give you more detail about this stuff. I'm currently working with the chair of the Medical Fitness Association, chair of the board of directors for the Medical Fitness Association, on this exact topic. We have created an entire course on how to overcome these perceived barriers. So if you guys want, we could take a break on occasion from joint case studies and start talking about this kind of stuff, exercise science principles, blah, blah, blah. But yeah.
Thank you.
It's
Thank you.
multifactorial.
Yeah. Thank you so much.
Yep.
Thanks for that question, Kevin. Anybody else have a question? I see Avery. Avery, go ahead.
Hi. So my name is Avery. I am entering my 3rd year at the DO program on the Philly campus at PCOM. And I really appreciated your talk. You actually answered a lot of my questions at the end of that last question, because I was going to ask about barriers, perceived barriers, cost. Personally, my mom is going through rehab and she's an uninsured patient. So I knew that she'd run out of those for her patellofemoral syndrome, run out of those free PT visits. And then like, where does she go from there?
Yep.
And I absolutely agree. I also have a health and exercise physiology bachelor from undergrad.
Nice.
I'm all on board for making sure we quarterback that whole continuum.
Exactly.
And it'll be cool to see that we can bypass PT when appropriate. But is there any talk at the government level to one day being able to see exercise as medicine or as preventative medicine? And really, like you said, it's an investment, not an expense.
Yep.
So my follow-up is, just the same way that sometimes PT can be covered by insurance, will we ever live in a world where more exercise past the PT is covered by
Yeah.
insurance?
So my first question to you are you going to be in Knoxville? Are you going to be attending?
I'm not going to be there in person, unfortunately. Right now I'm studying for my board exam, but I'll be there virtually.
Okay, because I'm going to start my presentation with the answer to your question.
Oh,
And
cool. Okay.
so I'm actually, I'm given the 15,000 foot view here, but I'm actually going back to 30,000 foot in 2 weeks in my presentation. So I don't want to spill too many beans, but there's an organization called the Physical Activity Alliance. It is a conglomerate of over 100 government, medical, and fitness organizations, and they've created a 20-year plan. And within this plan, there is a 3 to 5 year plan on getting the AMA to approve CPT codes and standardize EHR platforms, at the very least in the United States, but potentially globally. I am on a working group called the Physical Activity Assessment, Prescription, and Referral Working Group, where this is what our discussion is going on right now. As a matter of fact, we have a next meeting coming up in a couple days, and these are the big dogs. These are like CDC, AHA. I mean, these are the big dogs of like 20 different organizations. I can't even believe I'm in the group, but I get to see what's going on in the background. And the answer to your question is yes. It's currently about a 3 to 5 year plan to start getting these CPT codes approved, which will obviously open up the door for a lot more patients to be able to afford things. So it is being worked on, and I will go into a little bit more detail in Knoxville in a couple of weeks. But once again, these are all things that if you guys ever want to just, do like 3 case studies in a row, and then like a 3-to-1 ratio, 3 case studies, and then 1 session on this type of stuff, and then 3 sessions on case studies, and then 1 session on this type of stuff. I would love to do it that way. And I also know that I saw Brennan's question in the chat box saying, can we do the MS? That would be an interesting one for you guys to experience what happened.
Well, I will allow that to be our conclusion, because I appreciate you not spilling the beans, and this also gives me an easy transition to promote one last time here the mid-year meeting. So for anybody that's not already registered, Jeff will be speaking with us again at the mid-year meeting. That's going to be June 4th to the 6th in Knoxville. If you can make it in person, fantastic, or you can register virtually. We only do these meetings once a year, so this is going to be for 2021. Obviously, COVID got the best of us last year, but it's not going to stop us this year, thankfully. So with that said, thank you, Jeff, very much for another very informative talk.
Thank you very much.
And I can't wait to see you in a couple of weeks and hear the next presentation.
Yeah, really looking forward to it. Let me just quick say that at the meeting, I am going to review, some of this stuff is going to be a review at the meeting. But I'm just going to be covering some of the stuff in more detail and some different things as well. But I really look forward to meeting some of you in Knoxville, and appreciate your attendance because this is very exciting for me.
Sounds good. Well, we will leave it with that. And if anybody has any questions, you know how to reach us. Otherwise, we'll see you at the next event. Thank you, everybody.
All right.
Thank you.
Have a good night, everyone. Take care.